Good morning. I guess it's still morning. It's a pleasure to be here. I want to thank Larry and Medicine X for giving me the opportunity to present a patient-centered approach towards surgical pain, and I'm going to highlight this with a model I'm very familiar with, which is cesarean delivery. Now, I want to tell you a journey about how I got here. I was a medical student in South Africa, and then I did my anesthesia training in the United Kingdom, and then landed up at Stanford fortuitously. I've been here for 16 years, studying as both a clinician and a researcher, the field of obstetric anesthesia. And in many ways, it's molded my thinking, seeing different ways of management of pain. So the journey I want to take you on is the management of cesarean delivery pain. Now, before I begin, I think it's important that we take a moment and appreciate how privileged we are living in this 21st century. The problem I'm going to be discussing is a relatively minor problem, and a lot of the issues we discuss in Medicine X are relatively so. When you think about a cesarean delivery, historically used to be done on dead or dying women with a hope of potentially extracting a live fetus. So we've come a long, long way, and we're dealing with much smaller problems now, not that they aren't real problems. And by better management now, almost a third of deliveries now in the United States are done via cesarean delivery. And it's a not only well-managed surgical model, but we'll discuss some of the nuances and care on this. So for most surgery, if any of you have had surgery, and in fact, before I go any further, a quick show of hands, who in the audience has personally or had a loved one go through surgery in their lifetime? So vast majority. And of those of you who put your hand up, how many of you have been offered by your anesthesiologist or your surgeon a choice of the analgesic drugs, the painkiller drugs that you would want for your surgery, including doses? Have any of you ever been offered this option? So that's extremely telling. So currently in the United States and throughout the world generally, the way we approach pain is, it's a bit of a lottery in a way when you go for surgery. Whoever is going to be your scheduled anesthesiologist for the day, or for whoever you've been referred to from a surgeon's point of view, is going to decide what pain medication and anesthetic technique that they're going to use on you. So it's very individualized. It's lucky. You may actually get superb care if you have a physician who practices good evidence-based medicine. Equally, it goes all the way to ugly, and there's a huge variability in this model. So fortunately, about a decade or so ago, we started creating standardized protocols. They come by many names. So you have enhanced recovery after surgery, perioperative surgical home, clinical pathways, a whole host that all embody the basic principle of standardized care, where you apply the best possible evidence base behind a patient's management in different stages of surgery, with emphasis of good pain management for patients to recover quickly. So that's the principle behind this approach. And I'm a big fan of it. And usually there's a committee that gets together, and you go through all the evidence of what works and what doesn't work when you make up these decisions. What do we use for evidence? Well, what we use for evidence is ideally randomized controlled studies, drug X, first placebo, and we do big, well-designed studies. And then what you do is you are able to get this data and hopefully several different studies and pull them into big meta-analysis, and you get good evidence base by what works and what doesn't work. So this is the approach that we use for most of the time. The problem with this approach is that any study, like I mentioned, drug X versus placebo, is applied on all patients, and everyone's going to get it. They're going to get randomized to receive it or not. And we emphasize overall difference of effect. So basically what I mean by that is, what is the average effect? And if you see the graph on the right, you can see the lines in the circle. The average patient does extremely well, particularly for this drug. We were studying valdecoxib. No difference between them, which again is a reason why you have to do randomized controlled placebo trials, because while we were doing the study, the nurses were begging us for the blue tablet, saying it was amazing, and when we analyzed it, it didn't seem to work. But what this graph shows you is the average patient does very well, but in and amongst the average patient, You have those extremes on top that are just not doing very well, and some down below who really didn't need half the medication or the doses we gave to be comfortable. And the graph on the right shows a recent study that we did. We followed patients for months after delivery and waiting for their pain to fully resolve, no longer require analgesics, and for them to be fully functional. And if you look at 80% of the group of patients, and we looked at several hundred, do very well. Small pain burden that rapidly decreases down. But if you look at the top 20% of patients, they have much high intensity pain score, and it can go on for weeks and months, some patients several months. So the idea behind the population-based studies in a way is misleading because it doesn't necessarily tell you the patients that we really have to focus on. So the optimal way of doing this is doing targeted, individualized treatment protocols. So what I mean by this is you identify patients who have a low requirement, and then you target your middle group of patients, and then identify the patients with high analgesic requirements, and adapt the drugs that you give, the doses you give, based on this. So this is the principle of individualized treatment protocols. Does anyone disagree with this approach? Makes clear sense. The biggest problem with this approach is we have to know before surgery what group you're going to be in. Are you going to be in the low group? You're going to be in the high group? What do you actually need? So we have to pain phenotype prior to surgery to know exactly what patient is. So we turn to genetics. The problem with genetics is pain is a very complex phenotype. It is very subjective by virtue of how we report it, and there's a lot of genes involved in this. So we haven't really been able to get to the bottom of it, and your genetic predisposition doesn't really predispose you well to identifying patients at risk. The other option is to psychologically profile patients and look at things like anxiety, pain catastrophizing, depression, and a whole host of things that tend to predict pain. And this is well and good, but it's usually just the extremes of patients with suffering from these particular psychological areas that tend to predict pain better. So a completely different way of looking at this is say, well, I don't care who you are. I'm going to try and determine giving you a standardized pain stimulus prior to your surgery and see how you respond to that. So it's very simple. You can get cold, pressure, heat, even a touch that and you look at relative change with the touch. So these are things that have been applied to patients, and you look at general things like what they report in terms of the standardized stimulus, what their threshold and tolerance is. Again, the optimal technique has not been found to be very useful. It is variation in how effective they are. And remember, nothing can really mimic surgical pain. So having been involved in a lot of these, I think the fundamental problem with this approach is that we tend to be so paternalistic. What we're trying to do is we're trying to determine patients' pain phenotype. And then we look at our little recipe book, and then we go and apply what we think that they need. In no way along this conversation was the patient necessarily involved. So when we were looking at psychological scales that could predict pain, we threw in two very basic questions, non-validated, just like how much pain do you think you're going to be in? Scale it from 0 to 10. And then how much analgesics do you think you need? And this was able to predict 45% of pain after cesarean delivery and 21% of opioid use. And by the way, this is a very high prediction. Usually you're looking around 10 or 15% prediction because of the variability in pain. So it made us think patients have actually some insight into understanding their pain. So why not go direct to source? And it sounds unique, this, but it's kind of crazy that no one's ever thought of doing something as simple as letting patients choose what they would like. So fortunately for cesarean deliveries, we do them all with spinal. And we have a very effective drug called spinal morphine that we can put into the space. So we decided to allow patients to choose a low-high dose. These were two doses we'd used for many years. They were safe. But we know that you get more side effects with a larger dose with slightly better pain relief. And you get slightly less pain relief, but less side effects with a lower dose. So we randomized patients into a choice or not. Otherwise, they were not approached, and they had to just get our standard care. In patients choosing the low-high dose, and please don't lynch me, we introduced deception, so patients got a dose irrespective of what they chose. Because what we were trying to do is determine the power of choice, just giving a choice to patients, and how good patients are at actually choosing what they want. Okay? And they got, as I'm showing you in the back there, there's a little table that allowed patients to make an informed, standardized choice weighing the increased side effects with the larger dose, etc. So what do we find? Interestingly, offering a choice in isolation did not make a difference to pain and opioid use and a global satisfaction score. And I thought it would make a difference, but it didn't. But what is fascinating is patients who chose the larger dose interestingly had more pain and used more opioids. So they had insight prior to surgery from lifetime worth of experiencing pain or previous surgery into knowing that they were going to need more pain, need more meds, as well as experience more pain. And that graph on the left and the right, these are patients who received the same amount of drug, but the pain burden for those choosing the lower dose was less. And when we asked patients, what's the driver for choosing a smaller dose, they said side effects, and side effects. And actually, we showed that in the same study. If you give more dose, we know that you're going to get more side effects, and that's graphs of itching and nausea. And in patients who wanted the bigger dose, overwhelmingly, it was because they feared pain. So patients, in their own mind, were able to weigh these two options up of pain, but at the same time introducing side effects and making their own choice. And we have asked this question previously. There's always a trade-off in life. So prior to cesarean delivery, we said to women, these are potential outcomes after your surgery. What would you most want to avoid? Rank those that you most want to avoid. In addition, put the dollar amount, we gave them a theoretical amount of money to push towards it. So globally, patients would rather have less pain. Side effects don't predominate their decision. But this is a global. This is everyone included. And in and amongst this, there's patients who would rather avoid nausea and itching and sacrifice some pain. And it was one of the fundamental flaws with this is looking at a global population. But if you did have to make an estimate, patients generally fear pain more than. So I want to share one last study with you and then open it up to a Q&A session. And this is a study we've just completed, an extension of the previous study, and this is where we think it's going to go, and we'll roll this out clinically. We just completed it and analyzed it in time for Medicine X. This is the first time anyone's hearing about this. So again, randomized patients into choice or our standard care. Okay, and if you were given a choice, you were able to choose it based on a very similar graph about choosing lower dose for less side effects, higher dose, little bit pain. In and amongst all of these, you'll notice that the medium choice group, and obviously we couldn't give the exact recipes to patients because it's difficult to make informed decisions. We chose drugs and dosages that we believe are relatively safe within that environment, and they were really just selecting low, medium, and high. But in and amongst that, this is what we did. For no choice, our standard treatment was 150 micrograms of morphine, acetaminophen, which is Tylenol, and Motrin, ibuprofen or Motrin. The medium choice group was going to get exactly the same. So the understanding then is you can compare, does a choice make a difference or does a choice not make a difference? Okay, so they should be identical, those two groups, if choice didn't make a difference. And then for low, we gave a very small dose of morphine. We kept the same two drugs because they have low side effect profiles, no point denying any patient that. But for the high dose, this is patients who really requested a larger dose, we gave a much larger dose of morphine. This is 6-fold increase in dose. And we added a drug called gabapentin, which is Neurontin, a powerful analgesic. So you'd expect these patients should do better. So this is a graph from the study. So on the left is no choice, and then you've got the 3 relative choices. So the first thing let's focus in on, does choice make a difference? And again, it made no difference. You can see in blue the no choice, and the choice group look very similar in terms of their overall pain. And this is oxycodone dose, which is essentially our go-to analgesic. And this is a surrogate for pain, but also if you model pain, it looks very similar to this. What you'll notice is the low choice group had much less pain, and the high dose group had more pain. Okay, so again, patients had insight into choosing what they want. Now, appreciate that the low-dose group got 6-fold more morphine, which should last 24 hours. This is a graph of 24 hours, and an additional analgesic. And the high-dose group still had more pain than the low-dose group that got a very small amount of analgesia. Okay, so we couldn't mitigate this difference. But if you fast forward to the next 24 hours, that difference gets even bigger. Okay, so we are clearly dealing with patients who have not only insight to their own pain, but organically, they're going to have less pain after surgery no matter what. Patients who think they're going to have more pain afterwards are correctly going to have more pain. And we can reduce that and mitigate it a little bit with the drugs we give. There's still a long way to go, and we'll have to add additional analgesics to try and make a difference overall. So generally, I can't predict where we're going with this. I'm a big fan of standardized treatment protocols like enhanced recovery after surgical protocols. They've advanced the field, and it's simple. It's just applying knowledge that we have, getting all stakeholders. Interestingly, no patients are involved in developing these protocols, but getting all the stakeholders and applying the best evidence we have. Because believe it or not, we have a lot of effective drugs for pain after surgery. They're just not universally applied. So that's the first step. But the problem with standardization of care, and physicians have hated this because you spend years at med school learning, being an individual, and then suddenly what happens is you're going to follow this piece of paper that someone's decided on. So it was universally not accepted, and people didn't want to do it, but eventually we moved to saying it's the best thing, standardizing care and getting rid of variability. But the problem with these standard protocols is they don't give wiggle room for individual adaptation. So the principle behind this would be use your standardized protocol and then have patients' ability to choose and select within that bandwidth. And my other wish for the future is very simply a lot of studies, randomized control studies. The gold standard we do takes population averages and looks at differences for effective drugs. And my hope is that as we go forward, we'll be able to design studies better that actually focus in on this top 20%, top 10%, and the extremes, the outliers who need less and need more, so we can have a more targeted approach towards pain management. And that's all I have for you, and I'm happy. I've got about 3 or 4 minutes for questions. Otherwise, I will disappear to backstage. I don't know if there's a mic around, because someone has to pass a mic around. So I guess in the back there.
Yeah, thank you for that. That was very interesting, compelling data. I'm very interested in the group of people who do not have chronic illness and are not prior drug abusers who subsequent to pain medicine post-surgery become addicts, right, and avoiding that. I'm sure a lot of people are. And one of the things that I took from your comments is for the people in the high group, that one of the drivers of their, what might make them need more pain medicine is fear of pain, right? That might differentiate them from the low group. Any thoughts about any interventions prior to surgery? Fear is something we know how to treat, right? There are lots of any thoughts about if we intervene prior to surgery, whether that might reduce the fear and reduce their pain load and medication load? And also if you had any data on tracking who might become addicted post-surgery and whether that's different across those 3 groups of high, middle, and low.
Right. So it's a real problem. For cesarean delivery, 1 in 300 opioid-naive women, these are patients who are just normal, who show up for surgery, become chronic users of opioids after their surgery, and it is actually much higher in other surgical models. So 5+-fold increase of risk if you go for surgery becoming an opioid addicted, or at least persistent user beyond a time frame by which we would think you would stop using it. There are certain predictors, patients who are depressed. Fear is something that has been shown to predict acute pain, but is not that useful for predicting long-term pain. But again, we haven't necessarily focused in on patients who are more likely to become opioid addicts. Patients who already are on analgesics are more likely, and some surgical models are more likely to cause that. But it's a real problem that you discuss. In terms of an intervention, there are no studies to my mind that have done preoperative interventions. They're moving now more towards the high signal pain on day 1 and trying to manipulate that. And what the best intervention is, we still don't know. Is it pharmacological? Is it more psychosocial intervention? So question, I don't know who was first. Back there. Oh, I got to get you running around. You can.
You know, great talk, and 3 things come up for me. One is just a small thing, is I notice your specialty, and in your specialty, your patients actually get a little social currency by using less narcotics because they're sort of used to thinking about that for the delivery, even if they do go to C-section, so that's interesting. I'm also an addiction medicine specialist. I'm a physician in Kaiser, and so to that point, yeah, there is a transition period. We've found that it's really more if somebody's on the medication, 4 to 6 weeks, there's a point where they sort of tip into a chronic condition. But I also, from personal surgeries, not gynecological, experienced the difference in agents. Having one surgery and people are looking at you like, are you a drug user? No. But how much I needed versus another surgery using a different agent, and it was, far less than they expected. And it's just interesting that you're right. You can get sort of streamlined into side effect profiles, but are there systems that allow information from previous surgeries to be contiguous into new pre-op visits, and to sort of permit those sort of discussions? Do you want to do what we're recommending here, or did what you did before, suffice, and those sorts of things?
Yeah. So I agree with you. In the studies we did, previous surgery didn't necessarily predict the outcome, but patients have a lot of lifetime of experience of pain. So a global measure of what you think you need is actually very useful. And certainly if a patient reports doing very well previously, then you would just go back and offer them similar ones. The problem is different surgical models present with different pain. And I think one of the problems that we have now highlighted with obstetric, as well as other surgical models, is the overprescription of narcotics after surgery. It's sort of crazy how much gets prescribed in patients, believe it or not, who don't even need narcotics in the hospital. They still get given a standardized prescription. And there's a recent study showing on average 40 tablets are prescribed following cesarean delivery, and only 20 are used, and they sit at home in the cupboards waiting to be used. So it's a big problem, and patients are not involved in that decision making of how much would you like, how much did you need, where are we from that. And then the other problem is the go-to mentality of opioids for all pain, rather than using opioid-sparing drugs, and we have a lot that potentially be useful.
Changing the defaults in the EHR.
Correct. The problem is you can understand surgeons don't want to be hassled with refill requests, and it's trying to get that balance of an optimal dose, but there isn't an optimal dose. And again, it's the problem with population-based management, where you give everyone, and it's meant to take care of everyone. There's, in and amongst that, some that don't need a narcotic medication, and some that are going to require more, and also strategies to try and prevent accelerating or prolonged usage. I'm running out of time, but can I do one more question? Am I allowed, or is someone going to drag me off stage? Okay, one more, because you've had your hand up from the beginning.
Hi.
Hi.
I'm a healthcare experience designer, so there might be subtlety or rigor to a clinical trial that I don't understand. But I was wondering if when you gave these patients the option to choose a low or high dose, if they were also told that if they chose a low dose and it wasn't working, that it would be increased, or vice versa. Because for me, there's a psychological safety net to knowing that as a patient, that I can always step it back or increase it if I'm not liking the results that I'm getting.
Yes. So as with anything, there's PRN or as needed medication written up so you can treat the additional pain that you have. So that was clearly stated. We couldn't change the dose of spinal morphine because you get one opportunity to put it in, but everything else that could be modified later on was an option. So it was really, in a way, upfront what they wanted before they had the ability to adapt how much they needed post-operatively. All right. Thank you for your time. Appreciate it.